Our findings highlight several practical actions clinicians can take to improve care for patients living with obesity and pursuing transplantation. First, enhancing communication is actually essential. Clinicians should receive training to help them discuss weight sensitively, to recognize and mitigate weight bias that we spoke about earlier, and to support patients in a way that makes them feel respected and that the communication and the engagement is collaborative, where people are doing things with, not with the clinician doing it for them. Patients also expressed a desire for more personalized guidance related to the generalized advice. Secondly, the role and responsibilities with kidney teens must be made clearer. Many clinicians felt that obesity management was outside the scope of their role, which meant that led to gaps in care. So, for example, with dietitians in our study, we found that the transplant dietitians felt it should be the kidney dietitians doing weight, and the kidney dietitians felt it should be the transplant dietitians discussing weight. Hence, we were in a situation where no one really took responsibility. Establishing clear pathways and ensuring each team member understand what their contribution is will reduce this issue. Third, obesity care should be evidence-based and realistic. This includes adopting weight-based strategies to realities of kidney failure, acknowledging the barriers the patients face related to hunger, fatigue, and considering approaches such as bariatric surgery or obesity management medications, also known as incretin-based therapies, where we feel it's clinically justified. But what's really important there is we have holistic care. We don't just go down, for example, the medication route. We also consider the role that diet, physical activity also play within that model of care. Finally, addressing practical barriers such as food insecurity and providing stronger social support for people is incredibly important. This will help them to make long-term lifestyle changes. These steps can create more supportive and effective environments for patients trying to access transplantation. That's a really important question. And yes, we did say that there should be a paradigm shift, and we believed is urgently needed to ensure that there is fair and equitable access to obesity management, but also transplantation. So, at clinical level, obesity must be enhanced as a complex, chronic, relapsing condition that requires tailored, multidisciplinary care like other elements of obesity. It's not simply personal responsibility. It's not eat less and exercise more. And we really need to move away from that idea that it's a moral judgment towards that patient. Kidney clinicians need comprehensive training, as we said, on obesity, understanding its complex nature, weight stigma as well, but also communication skills to be able to discuss obesity in a compassionate and empathetic way while also bringing up weight in a non-stigmatizing manner. Decision making should be really collaborative. We need to be thinking about moving from potentially more rigid BMI cutoffs towards holistic, individualized assessments based on body composition and overall health, which I know has really been a movement forward since this original research was done. At a healthcare system, specialized renal obesity services are essential. They need to offer structured multidisciplinary support with dietitians, psychologists, physiotherapists, also linking in with obesity specialists, realizing obesity in itself is actually a specialist area and requires specialist support. So the connection between obesity services and kidney services is absolutely key. Ideally, we need really clear guidelines. Last year, the ASM brought out some guidelines related to obesity. The thing is that we still lack really strong evidence for weight loss interventions, particularly those individuals on dialysis prior to transplantation, which we were talking about in this review. We need to be considering, as we said earlier on, the wider determinants of health, things like food insecurity, social structure, and socioeconomic factors, all that can impact on someone's ability to make changes to their diet and their lifestyle that need to be acknowledged. Ultimately, in our view, there needs to be a shift to create a system that recognizes obesity as a medical condition in its own right, requiring coordinated care. And this needs to be prioritized for transplant access, both for the patients and the clinicians working towards getting better clinical outcomes and ultimately getting patients access to transplantation.